Welcome to today's Public Health Ontario Rounds presentation on the Prevention System Quality Index for 2023, Evidence and Data for Action. My name is Justin Thielemann. I'm an epidemiologist lead at Public Health Ontario, and I have the pleasure of moderating today's session. First, I want to acknowledge that I'm currently living and working in Toronto, which is the traditional territory of many nations, including the Anishinaabe, Métis, Sagi, Chippewas, Haudenosaunee, and Huron-Wendat. Toronto is covered by Treaty 13, signed by the Mississaugas of the Credit First Nation and the Williams Treaties, and is still home to many Indigenous people from across Turtle Island. I also want to acknowledge that my ancestors are settlers from various nations in Europe who immigrated to what is now Canada and the United States. Before we begin, I'll mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. So please use the Q&A pod if you have any questions during the session, and then we'll get to questions at the end. A discussion and question period will follow the presentation. If at any point during the session you experience technical issues, please email capacitybuilding@oahpp.ca. And I would like to state that as the moderator of this session, I don't have any conflicts of interest. So now it is my pleasure to introduce the speakers for today's presentation, Huda Shah and Hannah Diaz. Huda Shah co-led the development of the 2023 Prevention System Quality Index and works as a research associate epidemiologist on the population health team in Ontario Health. She has worked in chronic disease prevention through community engagement and brings over 5 years of experience as a health equity researcher. Hannah Diaz led analytics for the 2023 Prevention System Quality Index, and she is a senior research associate epidemiologist for the population health team at Ontario Health, where she's worked on multiple projects related to chronic disease prevention and measurement. And so now I'll pass it over to Huda.
Thank you for the introduction, Justin. Good afternoon, everyone. My name is Huda Shah. I'm one of the co-leads in developing this report. And I just wanted to give a shout out to my other co-lead, Nadia Pabani, who can't be here today because she's on parental leave. So congratulations again to Nadia. But this report really has been the work of the entire population health and prevention unit at Ontario Health. So luckily, I'm joined by one of my colleagues, Hannah Diaz. She did lead one of the analytics for the report, so I'm happy to have her join. And we hope that you're able to understand the PSQI. Now, this is a substantial report. It's over 70 pages long. So the goal of today's presentation really is to introduce you how the content is laid out in the report so you can easily access the information and data that you're looking for. And we also hope that you're able to share the content in today's report within your own organization or with other organizations that you're working with, to promote some meaningful dialogue around chronic disease prevention in the province. Before we get started, Hannah and I would just like to declare that neither of us have any financial support or in-kind support for this presentation, and neither of us have any conflicts of interest to declare. All the content in today's presentation is the property of the Population Health and Prevention Unit at Ontario Health, and Public Health Ontario is not responsible for any of the content for today's presentation. So by the end, we hope that you're able to understand the risk factors for chronic diseases in Ontario, but do so using a health equity lens. Now, this is when we take the historical context into account to understand the present day health disparities that are currently existing within Ontario. And we have a dedicated chapter for the first time in the 2023 PSQI on First Nations, Inuit, Métis, and urban Indigenous communities for this reason. And the PSQI really moves away from the individual level behavior to look at the policies and the programming. So you might know this as the systems and the structures, and how we can use the systems and the structures to reduce risk factors of chronic diseases in Ontario. And lastly, we're just really excited to be here so we can build some connections and collaborate better with you to move that needle on chronic disease prevention in the province. I just want to give a brief history of the PSQI to start with. Now, the PSQI started off back in 2015 as a Cancer Care Ontario report. and the focus was on cancer outcomes. As Cancer Care Ontario has merged into what is now Ontario Health, we've been able to move beyond cancer to include the top 4 chronic diseases in the province. Now, this includes cancer, but also heart disease, chronic obstructive pulmonary disease, and type 2 diabetes. And the latest report is actually the 6th report in the series. And we build on information from the previous reports. So if there isn't a significant update in a particular section, we'll actually reference a previous report so that you can read that for additional content instead. So the current report has actually just been released this past month. November 7th was our date. And we've actually included this link in the chat. If you haven't already accessed the report, or if we haven't sent you the report already, please do click on that link to access. And if you look over here at all the chapters in the PSQI, you can see that there are some of the popular risk factors for chronic diseases. So we have smoking, alcohol, unhealthy eating, physical inactivity. But in the report, we also call out the environmental substances that can impact our health outcomes. So what about the air quality that impacts our health outcomes, and substances like radon that are odorless and colorless, and how we might be exposed to those through our jobs? So what are some of the occupational hazards we have in being exposed to asbestos, for example? I think the COVID-19 pandemic really put into perspective the impact that viruses and bacteria can have. So we do have a dedicated chapter on infectious agents, and specifically the ones that we focus on are HPV and hepatitis B. I want to call attention to 2 of the new chapters we have for the 2020, which really bring into focus that health equity lens that I'm talking about. And I'll actually dive deeper into these 2 sections during today's presentation. But first, I just want to provide a brief overview of how the content is laid out for each chapter. Now, this is really going to be applicable for each of the risk factors of chronic diseases that we list out. So first, again, we conduct knowledge synthesis on what the latest evidence is to link that risk factor to the chronic disease outcomes. And then we look into what are some of the most effective policies and programs. What do public health organizations like the World Health Organizations recommend on best practices for policies and programming targeting risk factors? And then we take a look at what's currently happening in Ontario in terms of the policies and programming. And so after looking at Ontario and looking at the best practices, we try to understand where that gap is, or what we like to call the opportunities for reducing what's currently happening in Ontario and what the best practices are recommended by public health. And we also try to include regional level analysis in the report. So mostly we're reporting at the level of public health unit wherever possible. So we're able to use the data in this report for local level policy and program planning. So there's really opportunities to reduce risk factors in Ontario, and we'll talk about those in today's presentation. Now, each chapter is informed by experts in that specific area. So we have a collaborative effort with various internal and external partners. If you look at the screen here, we have an advisory committee and also an expert panel. And we go through multiple rounds of revisions and feedback with these committees. And scanning the list here, you can see that we really take a multi-sectoral approach to tackle chronic disease prevention because it's such a complex issue. We have representation from public health units, from research organizations, and also nonprofits, everyone working together to address some of the risk factors that are listed in this report. And representation from the relevant experts in their area of expertise is again considered for each individual chapter of the PSQI. I would just like to take this opportunity again to thank all of our wonderful partners in helping us develop this report. So it really is a multi-sectoral, multi-organizational, collaborative effort. As I've mentioned, the latest report differs quite a lot from its predecessors in 5 important ways. One really is that we're expanding beyond cancer to include the top 4 chronic diseases, as these really are the leading causes of death in the province. And wherever possible, data permitting, we take stock of the impact that COVID-19 has on policies and programming in Ontario. So we look at how COVID-19 impacted school-based vaccinations for HPV and hepatitis B. And thirdly, we also look at a health equity lens in reporting chronic diseases. So we do this by looking at the social determinants of health, not only in our knowledge synthesis, but also in how we report data. And Hannah will talk a little bit about our equity stratifications here. And lastly, I'll talk about how we developed a dedicated chapter for the first time in the PSQI on our First Nations, Inuit, Métis, and urban Indigenous populations. The PSQI can really be used in two important ways. Now, the first is really looking at that knowledge synthesis, the latest evidence on policies and programming that can address risk factors for chronic diseases. And again, we highlight the opportunities that are currently existing in Ontario at the local level to understand which factors might be more important to the populations that are being served within that specific region. Secondly, using the indicator data that we have present in the report, we hope that using local level data, you're able to understand exactly what might be most impactful for the specific region that you're serving. And also, wherever possible, we do try to track our indicators long term. So we try to have an understanding of the longitudinal trends that are present for certain risk factors in Ontario. So whether that's a risk factor that's moving in a positive direction or risk factors that have remained stagnant in the province, or also sometimes when we're moving away from what the current best practices are in public health. Along with the full report, we have also released other knowledge products to make it easier for you to access information in the report. So for example, if you don't have time to read the full report, we have just the thing for you. We have a 5-page summary document that's called the Key Findings document, and both of these are available in French as well. If you are more interested in reading about the data, then we also have supplementary tables that we call out in the report with additional data and information. And we also have a technical appendix. All of these knowledge products are available on our website landing page. Again, we've included the link to that in the chat in English and French. So at Ontario Health, we use what is known as the Equity, Inclusion, Diversity, and Anti-Racism, abbreviated as IDAR framework, which really calls out the historical wrongdoings that underlie present-day health inequities. Now, specifically, this framework acknowledges historical traumas like colonialism, like the transatlantic slave trade, and the present-day intergenerational effects that these have, and the resultant ongoing racism that's embedded in the healthcare systems and policies in Ontario. So this really allows us to build empathy in understanding why certain populations face more disparities in Ontario and why there is an uneven distribution of risk factors of chronic diseases in certain subpopulations in Ontario. This is why in the PSQI, we actually use a population health approach. We're moving away from individual level behaviors to really highlight the programs and the policies that can effectively address these risk factors for chronic diseases. So we do this for each of the risk factors that's listed, so all of the chapters that I just spoke about. And by using evidence-based policies and programming, those are actually proven to trickle down and change individual level behavior, but do so by making the healthier choice the easier choice for all. So again, we're using this health equity approach in really making changes equitable across populations so that the behavior change occurs in the populations that need it the most. This is why the 2023 PSQI really starts off with the social determinants of health chapter. Now, by having this as a starting point, it really allows us to understand these social determinants that are often the root causes and underlie the risk factors for chronic diseases and increase health disparities in certain populations. So once we consider these, we can go more upstream in our approach to understanding the policies and the programming at local levels that can address these root causes. And specifically in the PSQI, we call out 4. So we have starting off with food insecurity, and then we go into income, housing, and racism. So I actually want to read out some of the extensive body of research that links these factors with chronic disease outcomes. And I want to present some of the data that's the latest evidence in Ontario. So starting out with food insecurity, what we find is that adults who live in households that are food insecure are more than twice as likely to develop type 2 diabetes than adults who live in households that are food secure. Going over to income data in Ontario, we know that from 2005 to 2012, a greater prevalence of multimorbidity, now this is when you have multiple outcomes of chronic diseases, is found in the lowest income quintile compared to the highest income quintile. And we know that poor quality housing really impacts our health outcomes. So by exposures through respiratory toxins because of the cold and damp conditions, or whether that's because of overcrowded conditions and poor quality housing, we also know that this greatly impacts our mental health. So there's a reduced sense of well-being associated when we live in poor quality housing. We don't need to look too far to look at the impact of racism on health outcomes. So just data from the pandemic from June 2020 to April 2021 found that neighborhoods with higher amount of racialized individuals, now these are non-white individuals, had 7 times higher the COVID-19 positivity rate than neighborhoods that had less racialized individuals living in it. I just want to hit the point home that racism is a standalone determinant of health. So this means that your race will impact your health outcome when you're living in Ontario. This might be because your race impacts health-seeking behaviors, or your race might determine whether you have access to culturally appropriate healthcare services delivery within the province. And we know that certain populations actually face more racism than other populations, and research and evidence finds that within Canada, collectively, Black populations and First Nations, Inuit, Métis, and urban Indigenous populations face a greater level of racism, which is why it's so important for us to address anti-Black and anti-Indigenous racism in the province. And it's not to be conflated with some of the other socioeconomic factors that we see on the screen here. So I just want to highlight the next chapter that we have in our health equity approach here, which is a dedicated chapter for the first time. And we're really thankful to have worked with the Indigenous Cancer Care Unit, who provided some critical feedback on how to present content that's a bit more respectful and meaningful by avoiding making comparisons between groups, since it's not even helpful for the populations that are being represented in the data. So reporting separately on First Nations, Inuit, Métis, and urban Indigenous groups is a lot more meaningful than simply lumping them together under this umbrella of Indigenous. So in the PSQI report, we really shift away from this deficit-based approach where you're focusing on how much a group is lacking compared to another group, and shift that more towards a strengths-based approach to highlight just how much a group has overcome and faced. We know that First Nations, Inuit, Métis, and urban Indigenous peoples experience a greater impact on health outcomes from chronic diseases when they're living in Canada. And this really is because of a result of colonialism and violent assimilation efforts like Indian hospitals and residential schools. And the ongoing intergenerational trauma that's resulted from those historical contexts, and also the anti-Indigenous racism that's currently embedded in the healthcare systems and policy in Ontario. So we know that addressing chronic diseases in these specific groups will really require addressing anti-Indigenous programs and policies that are currently in place in Ontario. I'll now give it over to Hannah to provide a deeper dive into the data analysis for this report.
Thanks, Huda. So the PSQI features over 30 indicators, which fall into 2 categories. The first is risk factor prevalence indicators. These allow us to see where the Ontario population stands in terms of exposure to major chronic disease risk factors. So some examples include the percent of the Ontario population who are current daily or occasional commercial tobacco users, and the percent not meeting physical activity recommendations. Our main data source for risk factor indicators was the Canadian Community Health Survey. The second type is policy activity and exposure prevalence indicators. This includes data on how the province compares to evidence-based policy recommendations. For example, the minimum unit pricing of alcohol, tobacco taxation, and smoke-free policies in local housing corporations. These indicators came from a broad range of data sources. For instance, we received administrative data from the Ministry of Education and the Alcohol and Gaming Commission of Ontario. And we also obtained data from existing reports, such as PHO's report on immunization coverage. And the team also conducted primary research to obtain other indicator data such as municipal shade policies. So together, these two types of indicators tell a story about how Ontario is doing regarding prevention. The risk factor prevalence sets the context before sharing the policy recommendations and implications. This helps us to set measurable goals to see where we can improve and focus policy and program planning. So here's a list of some of our indicators to show an overview of the different data cuts we have for the PSQI indicators. For the risk factor indicators coming from the Canadian Community Health Survey data, we conducted all analyses by 5 equity stratifications, which I'm going to talk more about on the next slide. And a select few of these CCHS indicators were also analyzed for each of First Nations, Inuit, Métis, and urban Indigenous populations, and one was further stratified by PHU. We also have 2 alcohol outlet indicators. So these are presented by PHU only, as they were geographical analyses based on store addresses. And the household food insecurity and vaccine indicators came from Public Health Ontario reporting, thanks PHO, and these were available at the PHU level. And finally, we have 2 municipal level indicators, which were developed through primary research. These were placed in the PHU column on the table here, as we understand that some PHU boundaries align with municipal boundaries. And I'll provide further detail about the risk factor analysis stratifications in the next couple of slides. And I'll start with the 5 equity stratifiers. So we conducted analysis of CCHS data by sex assigned at birth, household income quintile, racial group, immigration status, and urban-rural geography. These last 3 are new to this 2023 report. And we added these new stratifiers and placed a heavier emphasis on equity in alignment with Ontario Health's priorities. So on the left here, I've included an image from our organization's Equity, Inclusion, Diversity, and Anti-Racism, or IDAR framework. And I've pointed here to the area of action pertaining to reporting and using equity data. So analysis of the risk factor indicators by these health equity stratifications did show some differences between groups. A detailed breakdown of these differences for each indicator can be found in the supplementary tables, and some examples will be shown later on in this presentation. As mentioned, select risk factors were also analyzed for each of First Nations, Inuit, Métis, and urban Indigenous population. So the indicators include the percent daily or occasional commercial tobacco users, the percent reporting long-term smoking cessation, and the percent who reported consuming more than 2 alcoholic drinks in the past week. And as Huda mentioned, we work closely with Ontario Health's Indigenous Cancer Care Unit to present data in a more respectful and useful way. As a result, we disaggregated results to respect the diversity of First Nations, Inuit, Métis, and urban Indigenous communities. However, small sample sizes within subgroups required us to pool all available years of data from 2015 to 20.
Okay, so now we wanted to provide a sample look at a chapter and how the content is laid out so that you can access information a lot more easily. Again, this will most likely be applicable to the chapters that are risk factors for chronic diseases. We decided to go with alcohol because alcohol is a bit of a hot topic this year. So again, as I mentioned, we start out each chapter by providing that latest evidence on the risk factor and how it's linked to chronic diseases. So specifically in this case, we talk about how alcohol is now categorized as a carcinogen, and some of that latest evidence that challenges that previous notion that low levels of alcohol are good or protective for heart health, when we know that alcohol is actually a risk factor for cardiovascular disease and type 2 diabetes. So this is why in 2023, the Canadian Centre on Substance Use, so the CCSA, has actually updated the guidelines for Canadians on how much alcohol should be consumed to avoid risk. So again, once we look at the latest evidence, we then review the effective policies and programming that's out there. So in this case, the World Health Organization really sets the gold standard with their global action plan, and they lay out some cost-effective alcohol policy options. So mainly this has to do with alcohol pricing and also alcohol availability. And now that we understand where the policy options lie, we can then look to see what's currently happening in Ontario. And we know that during the pandemic, several regulations in Ontario have actually been amended to increase the availability of alcohol. So I think that a few of you on this call today might notice that now we're able to order alcohol with our takeout and our food delivery, and this is not something that we were able to do just a couple of years ago. And, evidence finds that a higher availability of alcohol retail is associated with higher alcohol consumption. But what's the so what of it all? Who really suffers when we introduce policies that make it easier to consume alcohol? Well, in Ontario, what we find is something that's known as the alcohol harms paradox. Now, this is where individuals from a lower socioeconomic background, although they consume less alcohol than individuals from a higher socioeconomic background, they're more likely to carry the burden. So consequences like hospitalizations and chronic diseases. And as reported by the Canadian Institute for Health Information, so CIHI, just this past year in the pandemic, their report from 2021 found that hospitalizations due to alcohol had actually increased. And the study found that hospital emergency department visits due to alcohol were more prevalent among people living in rural neighborhoods and also low-income neighborhoods. And beyond just health outcomes, we know that heavy drinking also impacts gender-based violence, and it actually strengthens economic inequities. So when we align to reduce alcohol consumption in Canada, we're also aligning globally with the United Nations 2030 sustainability goals on achieving gender equality, ending poverty, and promoting peace. Now, once we understand exactly what the evidence-based policies are, so again, through the World Health Organization, we can understand how we can apply this to the Ontario context. And specifically, there's three major opportunities within the province for us to focus on. And this really has to do with one, alcohol pricing. Now, there is an opportunity for us to increase taxes on alcoholic drinking. And two, in terms of alcohol availability, there is an opportunity to restrict the physical availability of alcohol retail. And three is actually to enforce bans on ads. And we know specifically for social media, they're a little bit more laxed in advertising for alcohol compared to some of the other traditional media outlets. And this might specifically be important for youth and young adults who use social media, and it coupled with a greater availability at a reduced price, it might be easier now more than ever for youth and young adults to consume alcohol. And these populations are actually at a greater risk of suffering negative consequences from alcohol consumption. And we also know that early initiation into drinking is associated with alcohol use disorder later on in life. So we want to make sure that we're preventing initiation into alcohol as much as possible. So again, we're really focusing on programming and policies to trickle down and reduce alcohol consumption at the individual level. So really focusing beyond the individual to ultimately target that behavior. And now Hannah and I just want to give a little bit of an example on some of the indicators that we have in the PSQI. So I'll start off with a policy indicator. And over here on the screen, what we have is some of the alcohol minimum unit price for beer. Now, this is 5% beer in the province, and the bold numbers over here are the cost of beer in the province, and compare that to the World Health Organization recommendation. Now, again, this is the best practices that is recommended. Now, the World Health Organization actually recommends a 75% taxation on the minimum unit price of alcohol. And so you can see what's currently happening in Ontario compared to, again, that best practice. And, just a decade ago, we're not doing so bad. The difference between what's currently happening and the best practice is just 30 cents. But as we go further down, we start to see that there's a drastic change after 2018. So 2019 onwards, that discrepancy gets a lot bigger. And we know in August 2018, there was a policy change in the province. So in Ontario, the policy was changed to lower the minimum price for low content alcohol. And we see that, 2019 onwards, how that's made an impact. So that discrepancy is a lot bigger. And the largest discrepancy we see is actually in 2022, where what's currently being recommended is a lot different from what's happening in Ontario. So this really helps to show how improving public health practice has to be a deliberate effort. We need to set measurable goals as a province so that we can move in the right direction towards what's recommended by public health practice. And this is an example of a policy indicator. I'll let Hannah now go over some of the examples of prevalence indicators.
Thanks, Huda. So this indicator demonstrates alcohol availability. It measures the total number of alcohol outlets per 10,000 people aged 15 and older by public health unit in 2022. So this includes both on-premises and off-premises alcohol outlets, where on-premises refers to establishments where customers buy alcohol to consume on site, for example, restaurants and bars, and off-premises alcohol outlets refer to stores where customers buy alcohol to consume elsewhere. Addresses were obtained from the Beer Store, LCBO, and the Alcohol and Gaming Commission of Ontario and were geocoded in ArcGIS. In 2022, the total density of alcohol outlets in Ontario was 15.3 per 10,000 people. This analysis by Public Health Unit showed that this rate was as low as 7.6 per 10,000 people and as high as 24.1 outlets per 10,000 people in different parts of Ontario. Next up is our risk factor indicator, which reports on alcohol consumption behaviors in the province. This indicator is a good example of how the PSQI deals with pressing and timely public health matters. So the report has historically reported on the percent of adults exceeding drinking recommendations, which was previously 2 drinks a day for men and 1 drink for women. But we've updated this indicator to align with the 2023 alcohol guidelines. And on the next few slides, I've included figures to demonstrate how the equity stratifications provide us with additional context for this indicator, which is the percent of adults aged 19 and older who report consuming more than 2 drinks in the past week. The overall prevalence was 31.1% in Ontario, and we found that this was significantly higher in men than in women. And the prevalence showed a steady gradient by household income quintile, where each quintile was significantly lower than the highest, which was our reference value. And here's an analysis by racial group, where all categories were significantly lower than the white reference group. And here you can see the figures for immigration status and geography. So Canadian-born individuals were more likely to drink in excess of recommended limits compared to long-term and recent immigrants. And the same goes for folks living in rural areas compared to urban. And these are also statistically significant differences. And the exact numbers for all of these stratified analyses can be found in the supplementary tables. So this indicator looks at the percent of First Nations, Inuit, Métis, and urban Indigenous adult populations reporting drinking more than 2 drinks in the past week using all available data years of 2015 to 20. In the supplementary tables, we have further sub-analyses for each population by age group and sex where the sample size permitted it. One of the limitations of disaggregating indigeneity is the resulting small sample sizes, particularly for respondents identifying as Inuk. And as we will touch on later, missing data is an important limitation of our analyses, particularly for sociodemographic factors like indigeneity, which have been the basis for systemic racism and discrimination within the healthcare system and its policies. So these findings may not be an accurate representation. Importantly, there are limitations to the Canadian Community Health Survey's capacity to accurately reflect First Nations, Inuit, Métis, and urban Indigenous peoples, as the survey only captures a sample of the population, and a principal exclusion is people living on reserves. So these findings should be interpreted with caution. All right, so moving on, I'll provide an overview of some key report findings. So altogether, our indicators help us tell a story about what's going on in Ontario regarding chronic disease prevention. We have indicators showing movement in a positive direction, some showing areas for improvement, and some where we can't compare findings to those from our previous reports. That could be for different reasons, such as due to disruptions caused by the pandemic, data sources changing, or changes to the indicator definitions themselves. I'll start by sharing key findings from the indicators that are moving in a positive direction. So smoking rates in Ontario decreased from 17.7% in 2015 to 17, so that was from our previous report, to 15.4% from 2017 to 20 in this report. As well, 3 more local housing corporations have introduced a smoke-free policy across all of their properties since January 2020, and 3 more local municipalities strengthened their shade policy since 2018. And finally, the annual mean concentrations of fine particulate matter, which is a measure of air quality or pollution, decreased by 17% over the last 10 years. And here are some indicators showing areas for improvement. So tobacco taxes in Ontario fall below the level recommended by the World Health Organization. And similarly, minimum alcohol prices fall below the amount needed to see substantial reductions in drinking. As well, the percentage of secondary schools with health and phys ed specialist teachers decreased from the 2017 to 18 school year to the 2020-21 school year. And we also saw that public secondary school student enrollment in health and phys ed courses tends to decrease in higher grades. And finally, 16.7% of Ontario households during 2018 to 20 experienced some level of food insecurity in the past 12 months. And I'll finish off this section by talking about some of the limitations of this report. So first off, we have data limitations related to the Canadian Community Health Survey. So the data for our risk factor indicators are self-reported, and respondents of self-reported surveys tend to underreport socially undesirable or unhealthy behaviors like tobacco use and overreport desirable behaviors such as physical activity. Moreover, our risk factor indicators present different years of data due to availability of the CCHS data. For instance, not all content modules are selected every survey cycle, and multiple survey years had to be combined to conduct the stratified analyses. Therefore, the years of data selected for each indicator were the most recent consecutive years of data available to us at the time of analysis. Also of note, missing data were more prevalent for socio-demographic factors, including racial group and indigeneity, which have been the basis for systemic racism and discriminatory treatment within Ontario's health system and policies. Moreover, there are limitations related to understanding the impact of the COVID-19 pandemic, as it caused delays in updating information. So we were limited in obtaining the latest available data. As a result, we cannot understand the true impact of the pandemic on chronic disease and risk factors in this report. And finally, some of our policy indicators were limited by the response rate of organizations in providing us with updates. And more detailed information about our indicators and limitations can be found in the technical appendix. And I'll pass it back over to Huda.
Okay, so now we're nearing the end of our presentation, and we just really want to mobilize the knowledge in this report, and we're excited to create some meaningful and evidence-based dialogue around systemic and structural changes that we can make in the province to tackle chronic diseases. So there's really three meaningful ways that we hope that you're able to mobilize the knowledge in the PSQI. And the first is really, we hope it's been useful to look at regional level data. Specifically, we use the public health unit and the local level regions to understand areas that might need a little bit more attention. So this might be, something that you focus on based on the populations that you're serving within that region. Secondly, we hope that the PSQI really can be used as an evidence base across multiple organizations. So whether you're working in a community organization or a research organization, whether you're part of a local advocacy group for chronic diseases, or if you're working in public health, we hope that the knowledge in this report can really be used as a conversation starter on how we can address some of these issues that are relevant to our communities. And we recognize that, we tackle some big things in the PSQI, and the policy solutions are massive, and they cannot be done alone. So we hope that it's really used as a conversation starter and support maybe ongoing conversations that you're already having within your own organizations or across different sectors in developing new policies or in adapting some of the old policies that we have to promote well-being and health and to tackle chronic diseases in Ontario. Lastly, this work cannot be achieved in isolation. So we invite you to share the information with your local public health agencies, policy influencers, and policymakers, and how they can address some of the issues that are important to you and specifically to your own communities in terms of chronic disease prevention in Ontario. So lastly, we've sent out the report to our external partners listed on the slide here. And if you haven't received the report, again, we've included that link in the chat for you to access the report. We would love to expand our network in collaborating with knowledge mobilization efforts for the PSQI. and really just discussing further how we can use the information for the PSQI to tackle some of these risk factors for chronic diseases, and to again promote that dialogue. So if you aren't an external partner that we have worked with, or the ones that are listed on the slides over here, we would love to hear from you. And we've actually included an email in today's presentation at the end for anyone in the audience that would like to get in touch. So with that, both Hannah and I would really like to thank you all for your attention today, and we look forward to working with you. And here's the email that I mentioned, and we're now happy to answer any questions that you might have about the report or for today's presentation. Thank you so much.
Great, thank you both. That was excellent. So we'll now move on to the Q&A segment of the event. So we'll take questions from the audience. I see that there are already some in the Q&A pod, but please continue to type your questions into the Q&A pod, and we'll get to as many as we can. Okay, so one question asks, did you collaborate with anyone in public health for this report? And then I guess who did you collaborate with?
Yeah, so as I mentioned, we had multiple internal and external partners. So externally, Public Health Ontario was actually one of the organizations that we worked with. And then also different organizations that were responsible for different content in the PSQI. So specifically, if you look at the alcohol chapter, we collaborated with organizations that were focused on preventing alcohol consumption in the province. So there's a number of public health organizations, including from different sectors like research, community outreach, and then also in implementing programming and policies.
Great. Okay, another question. We noticed that age as a variable isn't in the supplementary tables, in the risk factor analysis, or in the social determinants of health. Could you please comment on where age as a variable falls into the index?
Yeah, I can start us off for this one. So our equity stratifications for the report, the decisions for that were informed by our expert panel and our advisory committee. So we kind of go to them for recommendations on which ones to include. So I think that one was out of scope for this report. Huda, do you have anything to add to that?
Yeah, I mean, there's certain indicators that we have where we were limited in terms of the different stratifications we could make in reducing the number needed for the analysis. So as Hannah mentioned, different indicators will have different limitations.
Thank you. Okay, the next question, I think it's referring to the poll about the new alcohol guidelines of 2 drinks per week. And the question, or the comment/question is, isn't it 0 drinks to avoid all risk, and then 2 drinks would be low risk?
Yes, so the guidance really is that no level of alcohol is safe for consumption, but the guidance really is for minimizing risk. So for minimizing risk, they do give a new guidance for 2 drinks per week. As previously, the guidance was a lot more than that. So just, taking note of the fact that it's been reduced a lot from the previous guidance.
Yeah, and I can add on to that. I see the confusion for the poll question. There was like the continuum of like guidelines, and like Huda said, the recommendation, the main one is 0. And in the question, we were trying to be specific with the one to avoid alcohol-related consequences, which, like the question said, yes, could be said to be low risk.
Great, thank you. We have another question about age. So has the determinant of age been considered, which I think you've already answered, but also this is also asking specifically about older adults. So how each of the determinants affects those who are older adults.
Oh, I can take this one, Huda. I think like with the last question, that one was just out of scope for this report. We didn't look at age this time.
Thank you. So the next question, so could the difference in prevalence of alcohol consumption by length of residence in Ontario partly reflect changes in culture and countries of immigrants over time?
Yeah, definitely. So that's why we wanted to highlight the different drinking behaviors. For new immigrants, that's a lot different from individuals who've been living in Canada for a lot longer. And I completely agree. I do think the culture has a lot more to do with it. You know, in the West and North America, we do have quite a drinking culture. It's something that we use to socialize with individuals. And maybe in other parts of the world, it's not the same, or they might use different substances. You know, I think that culture definitely has a part to play with it. It would be interesting to find out, you know, within those categories, the different cultures that are present and who's drinking more in which different ethnicity or racial background. But again, you know, we don't have access to that data for this report. So I would also be curious to understand just exactly how much the extent that culture impacts drinking behaviors.
Thank you. A question about where do we find the PSQI indicators?
So you can find some of the indicators scattered throughout the report in the body of the text, but if you're looking specifically just for the indicator data, if you follow the link that was sent in the chat to the report, you could go to the supplementary tables just to look at the data.
Thank you. Okay, next question. I like this visual with the puzzle pieces. So for example, collect, report, and use equity information is one of the inner puzzle pieces. Where is the visual from, and is there a link?
Yes, there is. You can access that online. So that's from Ontario Health Equity, Inclusion, Diversity, and Anti-Racism Framework, and we have a visual for that. I'll include the link in the chat now.
Thank you. Okay, is there a thought to including cannabis in future reports?
Yeah, so we actually do have separate knowledge products where we've covered cannabis use linking to chronic disease outcomes, and we do provide a link for that in the report. So if you're more interested in understanding cannabis use and some of the harmful effects that that might have, there's actually additional information. We have an evidence brief or summary that we call. So we do provide a link for that, and I can provide a link for that in the chat as well.
Great, thanks. And the next person is curious as to whether rurality and more specifically access to healthcare services such as specialist physicians has been examined in terms of a separate factor impacting health.
I can start us for this one. In terms of the indicator, we did have the urban versus rural stratification for our risk factor indicators. But Huda, maybe you could speak to this. I don't think that we go into more detail on that in the social determinants of health chapter.
So unfortunately, you know, data limiting, this is the first time that we're analyzing things using the rurality versus urban geographic regions. And so wherever possible, we try to do it. But if we were limited by the data, we weren't able to report on that. It is something that I think that now the Canadian Community Health Survey has included as a stratification. So we will, going forward, be able to understand a lot more in terms of risk factors for chronic diseases, that difference between rural and urban. And I would just like to call out that, you know, even in terms of rural areas, there's remote areas that we don't cover in that. So going north in Ontario, some of those remote areas are not adequately covered. So the data is quite limiting. I completely agree. But, you know, knowing that this is an important thing that when we look at specific Ontario regions and how important it might be for us to understand the exact populations that are within each region, how we can specifically serve those regions and those populations, is become more something that now public health researchers are more aware of, and something that we are trying to embed in our research more going forward.
Okay, next question. Did you look at screen time, i.e. watching TV, browsing cell phones, playing video games, as a risk factor for chronic diseases in the report?
No, we didn't look at screen time or sedentary behavior in this report.
All right, we're getting through a lot of questions. This is good. Next one, are there any plans for looking at climate change hazards and the impacts on health?
That's a great question. So I think that in our environmental section, what we do is we look at air quality, and that also sort of links to climate change and some of the impact that climate change is having on. So, I mean, in Ontario, air quality is actually getting better, and this is not something that I want to, link to climate change, but there are opportunities for us to link more to climate change in not just environmental substances, but also in terms of infectious agents. There's some research out there that is linking environmental changes to promoting new viruses and bacteria. And so there's going to be opportunities for us to align a lot more with climate change and link those to risk factors for chronic diseases, how climate change might actually impact or exacerbate some of the risk factors for chronic diseases. So something that's a really interesting topic, something that, again, more and more research is coming out and finding. But again, for the 2023 report, we're limited in terms of the latest evidence that we have. So this is a relatively new area, and I would stay curious in terms of finding out what the latest research is in this area, but something that we're definitely considering for future knowledge products.
Okay, we have another question about potential considerations for a future report. So I noticed that there were not representatives from rehabilitative care or geriatrics on the expert panel for this report. Would that be a consideration in the future?
We would love to expand our network. As I mentioned, we definitely have blind spots in the PSQI, in our advisory and expert panels as well. So we would love to collaborate further. Again, we've left that email. If you would love to provide some insight into a specific population or a community that you're from, we're happy to collaborate and work better with you.
And we have another suggestion for future reports. Also about age. So the absence of age is a big gap in my opinion. Some of these variables can have different impacts depending on age. For example, among children and among seniors. Will this be included in future reports?
Oh, sorry, you can go ahead.
Yeah, so as I mentioned, we do tend to look at working age adults in the PSQI. It is a huge limitation that we have. And in terms of chronic disease risk, we know that populations for older adults face greater challenges for some of these risk factors. So it's definitely something that we can go more in depth about, data permitting again, if we're able to explore that further.
And I'll just add something onto that because the question also pointed to children. I'll note that some of the indicators we have for adolescents, so like a 12 to 17 population, as well as adults. So that's something you can also check out in the supplementary tables.
Okay, thank you. And would vaping be included as well in the future?
Yes, so I'm actually just finding the link for that. So again, we do have other guidelines and other knowledge products that we've released on vaping and the health outcomes associated with that. So I've included the link in the chat for that. This was out of scope for the PSQI, so we decided to focus on specifically tobacco smoking, which is why we call the chapter commercial tobacco. So people are not confused if we just call it smoking. But we do have other knowledge products within Cancer Care Ontario and Ontario Health on vaping and the health outcomes related to that. So again, please do check out that link. And also, we had an earlier question about cannabis, so I was scrambling around trying to find the link for that. So please do have a look.
Okay, thank you. Okay, so the next one, alcohol policy work is about to take a step backwards with the expansion of sales to corner stores starting in 2025. Do you have any thoughts on how to adapt policy interventions to that new reality?
Yeah, so, unfortunately, sometimes policy changes are not aligned with public health practice and what's best practices for public health. I think it's really important for us to, again, focus on those populations that suffer the most, and just be mindful of implementing any programming that we can have for the specific populations that are more likely to suffer consequences and harms when we loosen up these policies and make it easier to intake alcohol. And then I think secondly, I would also try to focus again on youth and young adults, because again, as I mentioned, that age of initiation is very important in linking to later on alcohol use disorder. So, you know, what can we do in terms of policies and programming? Although things might be easier in the province in terms of accessing alcohol, what can we do at a more local level within our own communities to ensure that we're getting the right education out to certain populations and making sure that people are aware of the harms that alcohol drinking can have, especially consumptions at dangerous levels. So again, really, you know, focusing on the populations who suffer the most.
Great, thank you. I'm going to try to squeeze in one last question before we finish. This one's directed to you, Huda. You spoke about taking a strength-based approach when working with communities around chronic disease prevention. Could you speak more to that and what impact that would have in chronic disease prevention among underserved communities in Ontario?
Yeah, so that's a great question. And I think that in terms of using a strengths-based approach, we really focus on just how much the population has in terms of what they've accomplished, regardless of the barriers that they have. Using a deficit-based approach where we simply compare how much a group is lacking compared to another population does nothing to move that needle. So by just understanding what's currently happening in a specific group, we're then able to understand, okay, what are the next steps? It's more focused on solutions and resolutions rather than just simply reporting on what's missing and what's lacking. And I think that, you know, I come from a South Asian background. I've also grown up with this deficit-based approach of understanding that, oh, South Asians have a lot of diabetes. South Asians have, that is not helpful for someone like me in trying to adopt healthy behaviors. So I need to hear a bit more on what's currently happening in my population group and then work towards how I can personally, within my own culture, try to make some of those changes. That's a bit more helpful as a strengths-based approach rather than, again, focusing on what we're lacking.
Excellent, thank you. Okay, as we wrap up today's PHO rounds, I want to thank Huda Shah and Hannah Diaz for presenting. And I also want to thank everyone who joined us for today's webinar. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our programming. And a reminder to everyone, topic, the Ontario Public Health Convention will be held March 26th and April 3rd, 2024. So check out topic.ca for details, tophc.ca. Lastly, to access past PHO presentations and view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you, everyone, and have a wonderful day.